The clinical presentation can depend on three factors. One is the site of lesion. Site of lesion means whether the lesion is central or the lesion is peripheral. We've been talking about that this tumor is central, this is peripheral. Why that is so important? Because that presentation also can vary depending on the tumor, whether it's central or peripheral in location. Peripheral tumors usually will present late. They'll have to grow to big sizes and then they'll present maybe as a mass, or when they involve the surrounding structures, then they may present. Then other mode of presentation can be, or another reason for manifestations can be invasion of the neighboring structures. So they can be involvement of the pleura, they can be involvement of the intercostal muscles, they can be involvement of the intercostal nerves, they can be involvement of the ribs, they can be involvement of the diaphragm. So all these structures may get involved, and there may be more than that. We'll discuss as we go to clinical features, because which the patient can have clinical features. And the third factor which can govern the presentation is the extent of metastasis. Is the extent of metastasis that can also govern the clinical presentation. Now, if I talk about these metastasis, lung cancers, they very commonly spread with lymphatics. They're going to go to the mediastinal lymph nodes, pulmonary lymph nodes. In the module on anatomy, we discuss the different station of lymph nodes. We again see the lymph node staging, in this section when we go into the lung cancer. So, they spread very commonly to lymphatics, to the pulmonary lymph nodes. And the involvement of lymph nodes to ascertain whether lymph nodes are involved or not involved, and the lymph node staging is a very, very important factor for the staging of lung cancers and for planning a treatment for lung cancer. And it has been found that 26 to 32% of patients at the time of diagnosis will have mediastinal lymph node metastasis. So 26 to 32% of patients at the time of diagnosis will have mediastinal lymph node metastasis. Then apart from lymphatics, it can spread by blood. And by blood, the carcinoma lung, it most commonly goes to the adrenals. It can go to the CNS, it can go to the brain, it can go to the bones as well. And when it goes to the bones, carcinoma lung more commonly produces osteolytic secondaries. When it goes to the lung, it more commonly produces the osteolytic secondaries. Now, so these are the, I can say the reasons, or I can say the mechanisms on which the lung cancer can present to us. So, now let's see specifically what are the clinical features of a patient with carcinoma lung. Now, if I talk about the clinical features, they can be divided broadly into pulmonary and extrapulmonary symptoms. They can be divided into pulmonary and extrapulmonary symptoms. So, if I talk about the pulmonary symptoms first, one very important symptom, common symptom can be simple cough. It can be a non-specific cough. It is a non-specific cough. It may be persistent cough. It may be a persistent cough, or there is a change in cough. The patient can complain of a change in cough, increase in intensity, increase in pattern of cough. So, change in cough, persistent cough, non-specific cough, that is one of the presentations of these lung cancers. And why does this cough occur? It is either because of the irritation or the compression of the bronchus. So, cause of cough is irritation or the compression of the bronchus. Then another very, very important presentation of lung cancers can be dyspnea. They can be dyspnea. Now, dyspnea can occur because of different reasons. Dyspnea can occur because of airway obstruction or compression by the tumor, or we said there can be involvement of surrounding structures. Manifestation can be because of involvement of neighboring structures. If the pleura gets involved, there can be malignant pleural effusion. And that malignant pleural effusion can also lead to dyspnea. Apart from this, there is a large lesion. It can cause the parenchymal damage of the lung. So, there can be parenchymal lung damage by a large lesion. There can be parenchymal lung damage or damage of the lung parenchyma by a large lesion, and that can also lead to dyspnea. Then, apart from this, the patients can have wheezing. In fact, when wheezing will occur when there is more than 50% of airway obstruction. Then be more than 50% airway obstruction, that will be wheezing. Patients can have pneumonia because of erosion by the tumors or irritation. And as we discussed earlier, while talking about the small cell cancers, other symptom can be hemoptysis. So, hemoptysis, less than 50% of patients may present hemoptysis, but it is always seen more commonly in the centrally located tumors. And we have seen, the squamous cell cancers, they more commonly present with early hemoptysis. So, these are the pulmonary symptoms with which a patient of carcinoma lung can present. Then, what are the non-pulmonary symptoms that the patient of carcinoma lung can present? The non-pulmonary symptoms mainly will be, again because of involvement of the surrounding structures. That's the main thing. So, there can be pleuritic pain, and that's definitely because of either the irritation or invasion of the parietal pleura. Patient can have chest pain. They can be local chest pain, and that local chest pain can be because of involvement of the intercostal muscles or the ribs. Then be radicular type of chest pain because of involvement of the intercostal nerves. We discussed ribs, intercostal muscle, intercostal nerve, pleura, anything can get involved. Then a very important, we say syndrome, which occurs in, lung cancers can be a Pancoast syndrome. And Pancoast syndrome is mainly seen in apical tumors or tumors arising from the superior sulcus, and it occurs because of involvement of the, brachial plexus or the sympathetic chain. So, because of involvement of sympathetic chain, the stellate ganglion, brachial plexus involvement, that can lead to a Pancoast tumor. Then we have seen that carcinoma lung very commonly spreads by lymphatics to the mediastinal lymph nodes. So, if there is an extensive lymph node metastasis in the mediastinum, a bulk of lymph node, metastasis in the mediastinum is there, that can compress the recurrent laryngeal nerve and lead to hoarseness of voice. So, bulky lymph node metastasis in mediastinum that can compress recurrent laryngeal nerve. Compression of esophagus can occur. Esophagus just lies posteriorly, so, to the trachea. So, there can be dysphagia and there can be SVC, superior vena cava syndrome also. So, these are some important presentations with which a patient of lung cancer can present to you, maybe pulmonary symptoms or the non-pulmonary symptoms.